We'll take a look at the myocardium. With the myocardium, it's the fact that we're working with the middle part of the heart. If it's endocardium, then you're thinking more along the lines of valvular heart disease, perhaps? That's exactly what you're doing. So let's take a look at the myocardium and the categories of pathologies that come under or affect the myocardium. We'll take a look at CHF. Congestive heart failure. Know this as being end-stage heart disease. So anything that causes damage to the myocardium, from dilated cardiomyopathy to hypertrophic cardiomyopathy to restricted cardiomyopathy and so forth, eventually, if there's enough death that's taking place with the myocardium, are you not going to result in CHF? Now, the most common cause of CHF is going to be ischemic, Ischemic. So if your patient has something like an ST elevation in leads V1, V2, and V3, then you know there's a transmural myocardial infarction affecting which coronary artery? Good. Left anterior descending. And at some point later on down the road, your patient may develop congestive heart failure. You see my point. So ischemia would be a very common cause. Actually, it is the most common cause of CHF. CHF, final and common pathway of myocardial disease. Now, the way they'll approach this is dilated cardiomyopathy and hypertrophic cardiomyopathy would be relatively common, at least in developed countries. Is that clear? You want to think of dilated cardiomyopathy as being end-stage heart disease, just like you have cirrhosis being end-stage liver disease. You listen to what I'm saying. I'm drawing a lot of parallels here, and I'll keep doing this for you so that you don't waste as much time memorizing details when you should have been looking at the big picture the whole time. Or honeycomb lung. You've heard of that before, which means excessive fibrosis and more along the lines of end-stage lung disease, right? So here, dilated cardiomyopathy, including certain conditions that you'd find with restricted cardiomyopathy. And you all know about hemochromatosis. If you don't, you should and you will. With hemochromatosis, you'd know that the heart is being encased by iron. Think of it as such. So it may result in restricted cardiomyopathy, but if there's enough damage that's taking place to the myocardium, may you not result in dilated cardiomyopathy clinically? Of course you will. So how can you distinguish between the two? Well, you shall see. Alcohol-induced dilated cardiomyopathy? Sure, alcohol is unfortunately a common cause of this. Idiopathic, dilated. Hypertrophic cardiomyopathy. We had discussed hypertrophic obstructive cardiomyopathy with asymmetrical hypertrophy of the interventricular septum, resulting in obstruction of the outflow tract between the left ventricle towards the aorta, did we not? And when we did, we talked about the different maneuvers. Restricted cardiomyopathy, secondary to infiltrating diseases, such as, number 1, hemochromatosis, such as amyloidosis, which is then going to infiltrate the heart and therefore cause restricted type of cardiomyopathy. Or perhaps there's something called EMF, which is endomyocardial fibrosis. And there you go. What if you have fibrosis of the heart? May result in restricted cardiomyopathy. What kind of countries and what kind of populations might you then be looking for when you're dealing with endomyocardial fibrosis? You're looking at intense eosinophilia that may be occurring in your patient. Maybe later stages of Loeffler syndrome. And looking at countries such as Africa, such as South India, the subcontinent, with lots of restricted cardiomyopathy and fibrosis, endomyocardial fibrosis, not to be confused with endocardial fibroelastosis found in young infants. And we'll talk about those differences when the time is right. Restrictive, probably one of the trickier in terms of diagnoses because students tend not to be familiar with or not understand the full pathogenesis. Once again, to repeat, hemochromatosis sure could result in restrictive, but if there is enough damage to the myocardium, may result in dilated cardiomyopathy. Please do not ever forget that. Specific cardiomyopathies, ischemic, we talked about, may result in dilated cardiomyopathy, CHF, valvular-induced, hypertensive. While with hypertensive may result in concentric hypertrophy of the left ventricle, in which the sarcomeres are going to duplicate in parallel, resulting in what? Well, decreased size of the chamber of the left ventricle, thus, what kind of dysfunction? A diastolic dysfunction. Physiologically, what may then happen to your ejection fraction early on in hypertension? Are you able to preserve? Are there instances in which ejection fraction is preserved with heart failure? Sure there are. Hypertension early on, aortic stenosis early on. It's actually called heart failure of preserved ejection fraction being approximately normal at 55%. Is that clear? These are important points, and we've discussed this a couple of times. We will continue to do so that we reinforce this constantly. We have inflammatory. So here you have myocarditis. You might be thinking about viruses such as Coxsackie. You might be thinking about adenovirus, myocarditis, viruses. Maybe even perhaps part of rheumatic heart disease. Dr. Raj, I thought that was endocarditis and valvular heart disease, and you even told me there's 4 valvular diseases with rheumatic heart disease. Acute type of regurgitations and the chronic type of stenosis. Why all of a sudden are you talking about myocarditis? Because rheumatic heart disease is pancarditis. You heard of Ashkoff bodies, Anichkoff cells. Myocarditis. Infections, HIV, enterovirus, Chaga. Let's sit there, or actually stand up with me. Let's do the Chaga, Chaga, Chaga dance, huh? What am I referring to? Why do I say Chaga, Chaga, Chaga? Dilated, dilated, dilated. 3 different places. Obviously, I'm going to repeat this in 3 different organ systems. By Chaga, Chaga, Chaga from head to toe, dilated esophagus. What's this? Achalasia, acquired type. Where am I? Taking a cruise. Where? Down in South America. And I ended up acquiring Trypanosome cruzi. You pick this up and you have Chaga. And may result in acquired type of achalasia. What happens to the proximal esophagus? Dilation. Dilated esophagus. In the heart, what kind of issue? You might have a dilated infectious myocarditis. What else may happen? Dilation. I said 3 times, Chaga, 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 dilation, dilation, dilation. The third and final dilation would be down the intestine. May result in acquired type of toxic megacolon. Is that clear? Chaga is important for us. Endocarditis, infection. Metabolic disturbances, well, if your patient feels and tells you, hey, doc, I feel like my heart's going to jump out of my chest, and you find your TSH levels being ridiculously low. What is your diagnosis? And maybe even perhaps on a radioactive iodine test, you find diffuse uptake of radioactive iodine. Without a doubt, your diagnosis, please? Good. Graves' disease. We have diabetes mellitus. Of course, may result in issues in the heart. Infiltrating, hemochromatosis, amyloidosis, and do not forget, the sarcoidosis not only could affect your lungs, resulting in non-caseating granuloma, in which there might be bilateral hilar lymphadenopathy, but you can find these non-caseating granuloma perhaps in the liver, maybe as you see here in the heart. Do not forget that, please, ever. Now, with rheumatologic disorders, SLE, sure. You know about SLE, and you might have the autoimmune disease in which you have malar rash, but you could also have other types and other manifestations could be affecting the heart. You have polyarteritis nodosa, may also affect the heart. It's usually medium size, maybe perhaps small size type of blood vessels, might be affecting the heart. Scleroderma, you're thinking about fibrosis immediately, and dermatomyositis, in which you find skin lesions. You've heard of Groton lesions over the knuckles, heliotrope, and then muscle, in which finally it might affect your heart.